First of all, welcome to those of you who are able to join us in person. Thank you for doing so. We have a great turnout here. We also have lots of people joining us by webcast and by phone, so I want to welcome those joining in those two methods as well. So terrific presentation. Hopefully it wasn't too hard to choose between this and Covered California, and you've divided up staff and others to cover both, but we know there's a lot of interest in both presentations. I'm Chris Perrone with the California Healthcare Foundation, and we have a terrific briefing, longer than many of our briefings, so thanks for taking the time out of your day. We're presenting findings from a few of the studies that the California Healthcare Foundation has commissioned, looking at access to care for Medi-Cal enrollees and physician participation in the program. Some of you may have seen the work on physician participation already, but perhaps not had an opportunity to engage in a discussion about it. So we wanted to bring this body of work together today. And then we have a terrific reactor panel. I'll make introductions in just a bit. I want to start with just a bit of a personal story. I'm sure we all bring to this work our own personal stories. I got my start in health policy when I was an undergrad at UC Berkeley, working at in a doctor's office in downtown Oakland, a pediatrician who served primarily Medi-Cal enrollees. This was before we had the Healthy Families program. And it was a terrific exposure to our healthcare system, to the Medi-Cal program, to the challenges of working as a physician in the Medi-Cal program, serving this population, finding appropriate specialty referrals. This was many years ago. The program has changed quite a bit since, both in terms of the number of people that we're now serving in the program, in the way that the program operates. We've made a whole number of improvements and enhancements to the program. And this is really, I think, a terrific time to reflect on where things stand in this first year of the implementation of the coverage expansions under the Affordable Care Act. You have before you some packets that have both the presentations, the speaker bios. We also have an evaluation, so please, before you leave, complete the bio. This is the day of the great shakeout. So at 10:16, we're all getting underneath the tables in preparation for earthquake preparedness. I think this is something Toby would particularly appreciate as Director of Department of Health Services. We're not going to do that, but maybe those who are participating by webcast and phone can do it in their own desks. No, but we should just take a moment to reflect on and remind ourselves of preparing for the next earthquake. For those of us who live in the Bay Area, me right on top of the San Andreas Fault, many of my coworkers on top of the Hayward Fault, this is particularly an important issue, but no doubt for all of us. So I want to start by first just describing our body of work around monitoring access to care. The California Healthcare Foundation is engaged in a number of efforts around both monitoring access to care for Medi-Cal enrollees, but also improving it. And I'm going to talk a little bit today about an array of work that we have in terms of monitoring. Then we're going to then turn to presenting results from two projects that we commissioned, one looking at the California Health Interview Survey, the next from the National Health Interview Survey. Actually, the order of those presentations is just the reverse of what I just said. But comparing Medi-Cal access to care for Medi-Cal enrollees to access to care for Medicaid enrollees in other states, and comparing access to care for Medi-Cal enrollees to other insured populations in California. And then we're going to have a presentation on the work that we've commissioned on physician participation in the program. And then, as I said, a terrific reactor panel. So just starting off with our work on monitoring access, I hope you've seen a report that we did by one of Sharon's colleagues. I haven't introduced Sharon, but I'll point to her. One of her colleagues at the Urban Institute and Sharon led a study developing a framework for monitoring access to care. So if we wanted to develop a cogent, coherent set of measures to monitor access to care on a regular basis over time, what would that look like? What data sources would we use? What trade-offs would we have to make in terms of the measures? What new areas would we need to develop some new measures that we don't have now? So that report we published several months ago kind of lays out that framework, and then we're going to refer to it here in the presentation as well. We have the physician survey and the consumer surveys that we're going to be talking about today. We have some additional work that we're doing in concert with the Department of Healthcare Services on potentially avoidable hospitalizations as one way to measure access to care. We have a body of work that we are particularly interested in launching, and we're partnering with Janet and her colleagues at University of California, San Francisco, to look at access to specialty care. I think one of the things that we surfaced in our framework was that the data sources aren't as rich when it comes to understanding access to specialty care as they are when it comes to understanding access to primary care. And so we're kind of thinking about how one would go about measuring access to specialty care on an ongoing basis. How would one approach that? And I suspect that we'll want to engage many of you in that conversation about what the best methodology is and trying to overcome some hurdles. And then finally, one of our understandings, beliefs, perspectives at the California Healthcare Foundation is that we're not going to address this problem fully by spending our way out of it, given the budget fluctuations that we have in California, or by just by training new doctors. That the problems are more immediate than that, and we need to think about a variety of solutions. And clearly, the practice of medicine is evolving to more team-based care, to concepts like telehealth, to e-consults, and a variety of different strategies to address workforce shortages and challenges in access. And so we're beginning thinking about, to the extent that a lot of surveys now really are about measuring consumers' access to a physician, how do we broaden that perspective to incorporate the way that medicine is evolving? So the framework that I mentioned identified from a long history of really good literature on this topic, 3 domains of access. They are potential access to care. So these are measures like, do you have a usual source of care? Are there enough physicians available to serve the population? The second is realized access. So what's the actual consumer experience when they go to seek care? Did they have a doctor's visit in the last year? Did they have trouble making an appointment with a physician when they needed one? And then health outcomes, self-reported health status, whether people continue to smoke, rates of obesity, things like that. We're going to be talking today primarily about the first 2. And what I think is really exciting about what we've done is we've got these researchers, Urban Institute based in Washington, D.C., and UCLA based here in California, and they have done a really terrific job in collaborating on this work together to really synergize the way that they're approaching this look at access. And we'll talk more about just exactly how they're approaching that. I'm going to leave that difficult task to them. So I'm going to just start by introducing our speakers. You have bios in your packet, so I'm not going to spend a lot of time looking at this. And I will say that the bios came to us probably 3 times as long as this because these are really accomplished people. So know that even the succinct biographies that you have in your packet are just a tad of their many achievements. So we're going to start with Sharon Long, who's an economist and senior fellow at the Urban Institute. And she's also an adjunct professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. And then joining her in a presentation on the consumer survey piece is Ninez Ponce, who's professor at the University of California, Los Angeles, Fielding School of Public Health, Department of Health Policy Management, and was recently appointed as director of the Center for Global and Immigrant Health. Many of you may know Ninez for her work on the California Health Interview Survey, and we're going to hear more about that today. And then I'll go ahead, so we won't break in the middle, and introduce Janet Kaufman, who's to my immediate right, is an associate professor at the Philip Lee Institute for Health Policy Studies at the University of California, San Francisco. And Janet has been a long-time partner with us on any number of studies looking at a variety of elements of our healthcare system. So I'm really pleased to have all of them here today, and I'm going to hand things off to start to Sharon.
Thank you. Good afternoon. As Chris said, this is very much a collaborative effort between the Urban Institute and UCLA Center for Health Policy Research. Urban, we're in DC, and we've brought kind of a national perspective using the National Health Interview Survey, and then Ninez bringing the CHIZ California Health Information Survey to the table. So I'm going to start providing an overview of the framework that we're using for the analysis that applies to both surveys. Then I'm going to present the findings from the national perspective, and then Ninez is going to come and talk within California access to care issues. As Chris said, we are focusing on two of the issues that were raised in the framework on monitoring access to care, gaps in potential access and gaps in realized access. So when we think about the gaps in potential access, we're asking the question, is healthcare available to Medicaid enrollees? And the examples here would be, do they have a usual source of care? Are they able to find a provider who will see them? And then the second focus is on gaps in realized access. And this is, do Medi-Cal enrollees receive appropriate health care in a timely manner and in the appropriate setting? And here, these are measures like having a doctor visit, having a flu vaccine, not going without needed care. And so the goal for this monitoring effort is to assess the extent to which Medi-Cal is ensuring that Medicaid enrollees are receiving the care that they need in a timely way at the right time, in the right place, and at the right level of care. And so we are using two different data sources, the National Health Interview Survey and the California Health Information Survey. And the NHIS provides a national sample of the civilian non-institutionalized population, collecting information on health status, on health insurance coverage, on health access and affordability. So it gives us the profile of what's happening in California and the rest of the country. And then CHIZ provides a state-specific focus with much richer data available for California. And so it is the focus for that within state comparison. We are looking at both children and non-elderly adults. What I'm going to report on today is non-elderly adults, but we'll also be putting out information on children in the future. And then one of the challenges when you think about how to monitor access to care is, what are the benchmarks? And so we're going to rely on three benchmarks. The first is, how does Medi-Cal compare to Medicaid in other states in terms of access to care? The second is, within California, how does Medi-Cal compare to employer-sponsored insurance coverage? And then the third is looking within Medi-Cal to see how it compares for different population groups within the program. So under Medicaid's equal access provision, the state is required to provide Medicaid payments that ensure that Medicaid enrollees receive access that's comparable to that's available to the general population. There are challenges in determining what that means in terms of access to care. We know access to care varies for many reasons, including the characteristics of the individuals, their healthcare needs, provider supply, the healthcare market and infrastructure, as well as Medicaid policies. And so all of those are factors. For this work, we're focusing on three types of comparisons. The first is just a simple comparison of what do we see in Medi-Cal versus what do we see in Medicaid in other states. So it's how does access compare for Medi-Cal enrollees and Medicaid enrollees in other states. But we know that access can vary because of healthcare needs. And so the second comparison asks, how does access compare for individuals in Medi-Cal to individuals in Medicaid who have the same type of healthcare needs as the Medi-Cal population? So how do they compare controlling for healthcare needs? And then the third incorporates differences in socioeconomic status. So how does access to care compare for Medi-Cal and Medicaid in other states for people who have the same healthcare needs and the same economic resources? So it's three different perspectives on assessing access to care in the Medicaid program. So for this work, we're going to focus on that second measure, the access to care based on populations with similar healthcare needs. And we will, in the last slide that I present, I will show you what the implications are for the 3 different measures, and those are available in the tables and will be available in the report. But for just to keep this simple, for this presentation today, we're focusing on that measure that controls for differences in healthcare needs. So in order to control for differences in healthcare needs and comparing enrollees in Medi-Cal to enrollees in Medicaid in other states, we use a regression-based analysis. And so we're estimating a regression model that controls for variables that predict healthcare needs. In this case, that would be controls for age, sex, measures of self-reported health status, measures of self-reported disability, and then health behaviors. So the idea here would be that by making Medi-Cal population and populations in Medicaid in other states similar, we can look at differences in access for populations with similar characteristics. So in operationalizing this, what this means is that we predict what would happen for the Medicaid enrollees in other states if they had the same health status as the Medi-Cal population, and then compare that to the Medi-Cal population. And then would say that when we're then using those comparisons, we then check for statistical significance of the differences between the 2 groups, and we're using a 5% level here in terms of what counts as a statistically significant difference. So here's an example to show you what that means, and kind of on the operational side. So this is looking at gaps in potential access related to the most recent emergency department visit because the doctor's office or clinic was not open. And I should say that the numbers here differ from the numbers in your slide. We had a kind of a mix-up in the editing of the numbers between versions. So the numbers are a bit different, but the concept is the same. So the rows here are the 3 different measures we talked about. So simple differences between Medi-Cal and Medicaid in other states. The second row, regression-adjusted differences that control for differences in healthcare needs. And the third row, regression-adjusted differences that control for both differences in healthcare needs and differences in socioeconomic circumstances. So that first column is what we observed for the Medi-Cal adult population. So this is the actual level that we would see for the Medi-Cal enrollees. So there you can see it's 6% of Medi-Cal enrollees are reporting that their most recent emergency room visit was because a doctor's office or clinic wasn't open. The next column is Medicaid adults in other states. And so here, for the simple differences, that's the actual observed value. So 10% of Medicaid enrollees in other states report that their ER visit was because a doctor's office or clinic was not open. And there, the difference between the 2 is 3.9 percentage points, and that's statistically significant, as indicated by the asterisk there on the number. So the next row is what would we predict for those Medicaid enrollees in other states if they had the same healthcare needs as the Medi-Cal population. So as you can see there, we actually would predict that if they had those same healthcare needs, we would see less ED use. And so the difference there drops between the Medi-Cal and the Medicaid population. And then again, if we continue further and control for differences in socioeconomic status, we would see a further reduction there. Only 7.9% of Medicaid enrollees with similar healthcare needs as the Medi-Cal population would be projected to have an ED visit because the doctor's office or clinic wasn't open. So by controlling for those things, we make the populations more alike, and we're identifying differences that remain after you control for health policy differences or health status differences in socioeconomic differences. So with that as background, let me, and I should say, and that's the second row is the row that we are focusing on. So that's the outcomes we're looking at, the outcomes that are adjusting for health status. So with that, let me turn to the findings based on the National Health Interview Survey. And so here again, the research question on this part of the study is, how does access to care in Medi-Cal compare to access to care in Medicaid programs in other states for people with the same healthcare needs? As Chris mentioned, there's a framework that's been developed to conceptualize what we would mean by gaps in access, both in potential access and realized access. And part of what we've done here with the National Health Interview Survey and then with CHIS is to try to operationalize those measures with existing survey data. And so there are some differences between the 2 surveys, so our measures differ somewhat between the surveys, but all are kind of geared toward the same concepts of understanding access to care. In framing the measures, we've made them all indications of gap, so they all are negative findings, so that higher values indicate more problems with access to care. So here, where we're looking at gaps in potential access, there are measures such as does not have a usual source of care, reported difficulties finding a provider who would take a new patient, reporting difficulties finding a provider who would take Medi-Cal. So those are all gaps in provider potential access to care. The second set of measures are related to realized access to care, and here we've divided those into two groups, measures related to use of care and then measures related to affordability of care. And so these are the use of care, and so these are all gaps in receipt of care, so did not have a doctor visit, a dental visit, a flu shot, as well as delayed care because of difficulty getting an appointment in the prior year. In this group, we also put emergency department visits, so here high levels of emergency department use, or the measure we showed you before, most recent emergency department visit was because the doctor's office was not open, so indicators of access problems. And then the final group is gaps in realized access that are related to affordability of care. And here, we have a series of measures that are related both to unmet need because of affordability issues and delaying care because of affordability issues, as well as having difficulty paying medical bills or worrying about the ability to pay medical bills in the future. So all that, and here are finally some results. And so here, looking first at gaps in potential access. And let me just orient you to the slide first. So these are the measures that were in the last slide looking at potential access. The red bar is Medi-Cal. The blue bar is Medicaid in other states. Because we framed the measures all as indicators of gaps, longer bars indicate larger problems. So as you can see here, the red bars are all longer than the blue bars. So more problems in the Medi-Cal program than in the Medicaid program in other states. When we look at across the groups, you can see there unmet need for routine care, the first set of bars, that 13% of enrollees in Medi-Cal are reporting that they do not have a usual source of care, compared to 7% in the Medicaid programs in other states. And that the asterisk there indicates that that's a significant difference between the two. So as you look at this chart, you can see that we find significant differences for the first two measures based on usual source of care, but no differences between the last three measures. So here we would say Medi-Cal is doing worse on two measures and is doing the same as Medicaid in other states on three of the measures that we're examining. And so here, looking at the gaps in realized access that focus on use of care. Again, the same setup. The red bar is the Medi-Cal program. The blue bar is Medicaid in other states. And here, a somewhat more mixed story. We have, for the measures at the top there, that did not have a doctor visit, did not have a specialist visit, did not have a dental visit. More gaps for the Medi-Cal program than Medicaid in the other states, and those gaps are significant. For women, there's also a gap in receipt of pap smear, but that difference is not statistically significant. And then when we look at the ER measures, here we see that Medi-Cal is actually doing better than Medicaid in other states. So Medi-Cal enrollees are less likely to report high levels of ED use, and also less likely to report that the most recent ED visit was because the provider was not open. Only the latter is statistically significant on those measures. And then finally, the gaps in realized access around affordability measures. And so here, again, a somewhat mixed story with some positive and some negative. So the top bar, unmet need for care because of affordability, we see a gap there with Medi-Cal having more of a problem than Medicaid in other states. And again, on the bottom, in terms of worried about future healthcare costs and the ability to pay bills in the future, more of an issue for Medi-Cal than Medicaid in other states. However, when we look at the family having problems paying their medical bills or being unable to pay their medical bills, the families in Medi-Cal are actually doing better than those in Medicaid in the other states. So we see a significant difference there in Medi-Cal's favor, with more of those families, or less of those families, being concerned about And so when we summarize that information in this slide, and this is both the results that we've just looked at as well as the results that are based on the other comparisons. So the rows here are the simple Medicaid, Medi-Cal Medicaid comparisons, the differences that we've looked at, which are controlling for healthcare differences, and then the differences that are controlling for healthcare needs and socioeconomic status. So there are 18 measures that we looked at based on the National Health Interview Survey, and it's a mixed finding for Medi-Cal. In this setup, we've got the first bar where we're looking at simple differences. Of the 18 measures, 4 Medi-Cal is better. Those are the green box. 5, Medi-Cal is the same as Medicaid in other states, the blue box, and then 9, where Medi-Cal is actually doing worse than Medicaid in other states. When we control for health status and healthcare needs, we see some narrowing there where now Medi-Cal is better on 3 measures, the same on 6 measures, and again, worse on 9 measures. When we control for socioeconomic status, we don't see a change in statistical significance, so we see those same differences persisting, but we do see some mitigating, so the size of the difference does tend to get reduced by controlling for those differences in economic resources. But the bottom line here would be that although Medi-Cal is doing as well or better on some measures, it's continuing to do less well on 9 of the measures that we examined. So now I'm going to turn the podium over to Ninez to talk about the within California perspective on access to care.
Thanks, Sharon. So we're going to now move to California. This is using the California Health Interview Survey. And the questions now revert to within California. How do Californians with Medicaid compare to Californians who have employer-sponsored or job-based coverage? It's going to be the first set of the results. And then the second says within, then zooming even more, among Medi-Cal enrollees, might there be differences regionally? Might there be differences across race, ethnicity, and also by language? So the indicators that we use for the California Health Interview Survey are very similar to the National Health Interview Survey, but not everything is completely aligned. There are also some measures in the National Health Interview Survey that are not in CHIS, and some measures in CHIS. For example, a lot of language access measures that are not in the National Health Interview Survey. So in the interest of time, I saw 10 minutes, but does that mean that was mine and Sharon's time? No. Okay, so great. So this potential and realized access is a construct that I think the utility of it is it helps policymakers think about what can be intervened on a supply access provider level, and what can be intervened on. Realized access is on the quality of care levels. I think of it that way versus is it potential, is it realized? And that's how I think about it. You know, how connected are you, and are there disconnects that can be intervened on? So that would be the potential access. And then the realized is once somebody is in, and then are there some interventions that could improve the patient experience. So think of it that way. So these are our measures, and I'm not going to go over there in detail because you'll see them again once we show the report card. The realized access, as I said, is different from potential access, and then we sliced it even more because realized access gets at both utilization, the use of care, and it also, since we have several here, and then it also gets at affordability. You know, was the hurdle in the experience because of cost, because of insurance, maybe insurance limits. So can everybody see that? Okay, great. So this slide looks at gaps in potential access. In this case, we reverse it. So the crimson now is Medi-Cal, and the blue, go Bears, is ESI. Actually, no, it shouldn't be. We should go the other way. So Medi-Cal. And so what we have here is a set of measures, hard time understanding a doctor in the last visit over the past 2 years. was it because of a language barrier that led to this hard time understanding a doctor? Was it because the usual source of care changed because of your insurance? Was it because the usual source of care is the emergency room? You don't have a usual source of care other than the ER. The personal doctor is not the main medical provider. And then the last one is sometimes never you're not able to get a doctor appointment within the past 2 days. And as Sharon said, the longer the bar, the worse it is. So the longer the bar, with Medi-Cal being in crimson, we're seeing here that these particularly bottom measures have significant gaps, where Medi-Cal looks like it's faring worse than those who are covered by employment-sponsored insurance. There's also some significant findings up here, but these are smaller gaps. Gaps in realized access now, this is looking at use of care. And in use of care, also again, zooming in on the bottom, can't find here, bottom bars. Again, crimson is Medi-Cal and ESI is blue. And we have then the gaps here in the preventive services, mammograms, and flu shots. We have gaps there that are significant, and but fewer than we saw in the connection to the health system set of indicators. In affordability, we had 3 measures for affordability, did not get help for mental health due to cost, delayed medical care due to cost or insurance, and delayed getting prescriptions due to cost or insurance. And these bottom 2 here show that Medi-Cal enrollees are reporting higher rates of these delays due to cost, both to medical care as well as to prescriptions. Well, I think I just zoomed through my slides. Our key findings. Our key findings. We don't have the green bar, which is Medi-Cal doing better than ESI. There are a number of measures where Medi-Cal coverage and ESI coverage fare about the same. And the gray is where Medi-Cal coverage then it's worse compared to ESI. And again, what our analysis, I think what's really neat about our analysis is that we don't just look at the simple differences, the raw differences. We adjust for health status, which is what we showed you today. So we get at the are the performance measures then get at the health status, all things equal in terms of health. And we're seeing that the gray, in this case within California, the gray bar does shrink. Once we account for, because Medi-Cal enrollees could be sicker. So accounting for that, then the worst measures then go from 15 to 10. And then we didn't show this today, it's preview for maybe later, 2015, that we have then for the SES measures that not only are Medi-Cal enrollees perhaps sicker, but we all know they're poor. So getting at then the SES part, then it shrinks even more. Then the measures where Medi-Cal were doing worse, faring worse than ESI, then it's fewer. Okay. We also looked at then we zoomed in on Medi-Cal enrollees and asked and examine whether there were perhaps regional differences. And I know Janet's going to show some regional differences in her presentations. We actually didn't see, there weren't any clear patterns that emerged in terms of regional differences, and that might be because our regions are too broad. No clear patterns, like LA didn't always do the worst, for example. Actually, Sacramento, in some cases, did poorer than other places, but it wasn't very clear, except perhaps the North Sierra counties reported fewer access problems. Race, ethnicity, very important, given the high proportion of racial ethnic minorities in the Medi-Cal program and in the newly insured. And so in here, Latinos fared worse on 2 of the 18 measures, and Asian and African American populations fared worse in 1 measure and fared better in another measure. So I think that that's good news in terms of the disparities within the Medi-Cal population, and also the measures were, well, let me get to the English proficiency. The 2 measures where there was differences among Medi-Cal enrollees, among LEP and those, were hard time understanding the doctor, for example. And then that hard time understanding the doctor also mapped very well with the Latino, that 1 measure on access measures. So I think that we're going to probe some more in terms of regional differences, but right now within California, it seems like there are fewer disparities by race, ethnicity, and English proficiency. So our next steps. We want to examine the changes over time in access using newly available 2013 data. And I know that everybody, I hope, who came here to look at 2014 data? So we don't have it yet, but I think this is a good slice in time. This is a good moment in time to look at it before, how the system is performing pre-ACA, and also this is 11-12 data, which has the lip transition. So we have some of the newly insured in that program in this data set. I think we want to be prepared, like the earthquake prepared. So we want to be prepared in knowing where our system is at right now. We conducted analysis on children. We're not presenting that today, but we have that in the works. We also, and I think this is very important, again, this is part of what I think is what distinguishes this work, is that we do have very interesting analysis where we include socioeconomic status. And I think increasingly we're thinking of, is the Medi-Cal package just all clinical, or perhaps we should think about all these wraparound services like housing, and transportation that gets at that. And then we hope to publish the findings in spring 2015.
Thank you.
Oh, this is our acknowledgement slide.
So before handing things off to Janet, I just wanted to briefly say, and I meant to say in my intro about this issue of the time period of this data. We set out to take a deeper dive than we normally do in terms of access to care and how it differs for different populations within Medi-Cal, how it differs in Medi-Cal versus other states. Clearly, we've done that. This was established for a baseline. But we have also conducted a general population survey on a much smaller scale in the CHCF that does not allow us to go nearly as deep, but does provide some initial glimpse of what the picture looks like in 2014. And I'll say that, so the sample sizes are much smaller. The sample size of Medi-Cal enrollees is about 200 people. But it's generally, when we did this a few years ago, we found very similar findings with that kind of general population survey, small sample, than as we did with our examination of much larger surveys. So I feel pretty good about the findings from 2014, and I will say they were remarkably consistent. So while this may be kind of really about the baseline and what the picture looked like a few years ago, I think we can be pretty confident that the picture looks very much like this today. So just think about that as you're sort of processing the information. As we think about the next steps, it's not like the world is much brighter or the world is much bleaker than it was. It probably looks very much the same. So it doesn't mean we won't look at the CHCF in 2014 and report the kind of depth that we have here today, but just don't want that to sort of cast a pall over the discussion today. I think we can take, I don't know if it's comfort, but it's well, we can be confident that the picture looks very much like what Inez is presenting today. So now to Janet.
Okay, well, thank you very much, Chris. Let me get a little situated here. Okay, so this work that I'm going to present is from the report that our team at UCSF released for California Healthcare Foundation in August. It too presents 2013 data. So, but again, I think that, as Nina says, it's an important moment in time, and it's going to give you a sense of physician participation in Medicaid, if you will, on the eve of healthcare reform. So before we had the Medi-Cal expansion, it's the situation. Before I go further, I want to give out a shout out to one of our research team members who's here, Margaret Fix. Margaret is the person who keeps us in track to make sure the surveys get out the door, to make sure all the responses are entered properly, and does a lot of our data analysis. So we want to thank her. Also want to thank the medical board, which has just been a critical partner in all of this work. So I'm going to be talking about potential access to use the framework. And the question I'm going to be asking and answering is there a doctor in the house who takes Medicaid? Or said in a more academic way, are a sufficient number of physicians participating in Medi-Cal to provide enrollees with adequate access to care? Do we have enough physicians on the supply side in Medi-Cal to provide access, for there to be a chance for realized access to care? So our methods are, this is a survey of physicians. We're shifting gears from hearing about two very important consumer surveys to a survey of physicians. And this is actually the third survey that our team at UCSF has done in partnership with the medical board, where we've looked at Medi-Cal participation. And so this is a survey that was mailed to California physicians with their licensure renewal materials and this was mailed out to folks whose renewals were due in June or July 2013. Here in California, with our medical board, we have a biannual, a 2-year renewal cycle. So everybody has to renew every 2 years. And so what we did is we really have about 1/12 of all the physicians who are due for licensure are in our sampling frame. And so the survey gets mailed out with the license renewal paperwork and with a mandatory survey that the medical board administers to all physicians. And physicians can either respond by mail or online. About 75% choose to respond online. And we analyzed, of that group of physicians, we analyzed responses for the subset that we thought was most relevant for looking at the question of Medi-Cal participation. So are you practicing in California? You know, if you maintain a California license, but you're actually practicing in Nevada, well, that may be nice for the folks in Nevada, but it doesn't really help Medi-Cal beneficiaries in California. Not in training. We wanted to look at folks who were fully finished their residency, their fellowships, and people who said they were providing patient care at least 20 hours per week. So physicians for whom patient care was clearly a major professional activity. And so we ended up with a sample size of usable responses of 3,499. And of those who would have been eligible for inclusion, that's about a 63% response rate. Now, that's not 100%, but for a physician survey, it's pretty darn good. And it really, this is a testament to our partnership with the medical board, that they're willing to let us stick the survey in with the licensure renewal materials so that we capture our physicians at a moment where they have our attention. It is voluntary, but it comes with some things that are mandatory and pretty important. You know, don't renew your license, you may not be practicing. Okay, so what are our questions? So from the voluntary survey, we asked about the type of practice. You know, are you solo, group, or clinic? We thought that would be important. Whether you're accepting new patients by payer. So we asked not only about Medi-Cal, but about other payers so that we could do a comparison. We asked about the distribution of patients in the practice by payer. So what's your volume of Medi-Cal, your volume of Medicare? And then from the mandatory survey, we could link in some questions on demographics, specialty, and practice location that were important. Okay, so here is the start of our results. And let's see. So if we'll just start over on the left, the far left, that's all physicians. And we'll see there that with private insurance, about 79% of our physicians in 2013 said that, yes, I'm accepting new patients with private insurance of some sort. And that compares to 75% of Medi-Cal, 75% Medicare. So there's a statistically significant difference there, but Medicare and private insurance, pretty similar. But then go to Medi-Cal, that's the gold bar, go Bears again, for 62%. So only 62% of the respondents said that they were accepting new Medi-Cal patients in their practice. So quite a big drop off there. The rust-colored bar there is the uninsured, only 44% accepting new uninsured patients. So if you have Medi-Cal, physicians are more likely to participate in Medi-Cal than they are and accept new Medi-Cal patients than uninsured, but much less likely than private insurance and Medicare, and that pattern follows through. In the middle, we have PCPs, primary care physicians. We define that as family physicians, general internists, general pediatricians, general practitioners. And then over on the right side are the non-primary care physicians. And your point estimates change, but your pattern is the same. We then looked by, practice setting. We thought that practice setting would be an important thing to look at as well. Let's see if we can get that back. Okay, and so what we see here is that physicians in community health centers and public clinics were the most likely to report accepting new Medi-Cal patients. No surprise there, for two reasons. One, it's the mission of these clinics to serve low-income folks, and secondly, in the Medi-Cal program, they get enhanced payment rates if they are a federally qualified health center. Down on the bottom, the solo practices, 44% accepting new Medi-Cal patients, and the private group practices in Kaiser in between. Okay. We're going to look at geographic regions now across the state. And I will caution you here, we'll talk through these, but these are really big geographic regions. And I wish we could drill down further, but this is the best we can do given our sample size, especially in the rural north. So just be aware that within any of these regions, there may be a big variation in what you observe. And so to try to walk you through this, we figured out what the statewide average percentage of physicians accepting new Medi-Cal patients was, and the confidence interval around that. So if you see a green region, that's a region that fell within the 95% confidence interval around the statewide average of 57%. And this is the primary care physicians here. So some regions average, a few regions, Los Angeles and North Valley, Sierra, which would include Sacramento, above average, others below average. If we turn now and look at non-primary care physicians here, and you can't really see it on the slide, but our statewide average is 64%. So the Bay Area and Los Angeles at about the average, San Diego below, and a number of counties, a number of regions above average. So definitely there's some mix in the rates of participation across the regions. I should also say here, we don't have a slide on it, but among the non-primary care physicians, when you tease that out, you also see a lot of variation depending on the specialty that you're talking about. So now I'm going to switch gears a bit. Having talked to you about the acceptance of new Medi-Cal patients, I want to talk about volume of patients in the practice. So what proportion of the patients in your practice are enrolled in Medi-Cal? And so if we start down at the bottom there at the dark blue bars, and again, we've split the primary care physicians from the non-primary care physicians, about 33% of the primary care physicians know Medi-Cal patients in the practice. They just are not participating in the Medi-Cal program. 30% of the PCPs, same thing, just not participating. If we go up to the top, to the orange bar, that's physicians who reported that 30% or more of their patients are in Medi-Cal. we chose this threshold. There's certainly others you could choose. We chose this one because, as Toby knows, this is the threshold for eligibility for the Medi-Cal incentive payments for electronic health records. So we thought, well, if that it makes sense to use the same threshold as the state is using to determine who qualifies for those Medi-Cal incentives. So here we see about 22% of the PCPs, slightly more than 1 in 5, have 30% or more of their patients on Medi-Cal, only about 16% of the non-primary care physicians. Another way of looking at this, and I will hustle here, is to plot the distribution of Medi-Cal visits across all physicians. So we asked the physicians, well, what percentage of your patients are in Medi-Cal? Is it 30%, 20%? And we added those up. And the short answer here is that we find that about 40% of the physicians care for 80% of the Medi-Cal beneficiaries. So there's definitely an uneven distribution. Now I want to look quickly at adequacy of supply. Given the participation rates that we have, do we have enough Medi-Cal physicians to meet the state's needs? And so here what we did is we calculated ratios of full-time equivalent Medi-Cal physicians per 100,000 Medi-Cal enrollees. So we added up, we figured out what percentage of your patients are in Medi-Cal. Let's add that up and get a full-time equivalent number, and then take a ratio of that to Medi-Cal enrollees. And for the enrollees, we use DHCS's data on that. And so what we see, and here we're comparing 2011 to 2013. So we say we do have a bit of an uptick between 2011 and 2013. And I know the first time that Margaret and our other programmer ran this, I made them run it again because I said, I don't think this is right. Well, it turned out it was right. And most of this is we really have had a little bit of an uptick in the number of physicians in the state. And we're also seeing a few more physicians reporting that they're participating in Medi-Cal. Not high volume, but small volumes. And so that's what's driving that. But the key thing, the most important thing I want you to look at is that straight bar on HRSA recommended ratio. This is a recommendation HRSA developed in the 1990s to say, well, what's the ratio of primary care physicians to population that's necessarily to provide an adequate supply of the primary care physicians to the population. And you'll see that even with the uptick between 2011 and 2013, we're still way below that ratio that HRSA would recommend. And that is a ratio, by the way, that was derived from estimates from Kaiser and other kind of closed model HMOs. So I think there are even legitimate arguments about whether that's really even feasible when you have more PPO type of products. So real quickly, one really important question about this line of work is how reliable are the physicians? How good are they at estimating their Medi-Cal participation? We have conducted a secret shopper survey, again with funding from the foundation, where we had trained interviewers. We partnered with some colleagues from University of Chicago and University of Pennsylvania to have folks call up and claiming to be either Medi-Cal patients or privately insured patients and see what responses they got from the schedulers and the practices. And what we found was that the physicians overestimate the availability of new patient appointments. But the degree of overestimation is similar for patients with Medi-Cal and private health insurance. So I think we've got overestimates of Medi-Cal participation, but we've also got overestimates for private insurance, at least in terms of taking new patient appointments. So this is the new patient appointment. So clearly, I think this speaks to the need to use multiple methods to answer these questions about access. So what are our key findings? Physicians less willing to care for Medi-Cal patients than patients covered by other forms of insurance. 40% of physicians provide 80% of Medi-Cal visits. Medi-Cal patients just are not evenly distributed across practices. 62% statewide accept Medi-Cal patients, but rates vary substantially. And Medi-Cal meets federal standards for non-primary care physicians per enrollee, but falls below the standards for primary care physicians. And with that, just want to acknowledge our funders, our partners, our research team, and look forward to our reactor panel.
Great. Thank you, Janet. We're going to shift gears to our reactor panel, and I'm going to welcome Toby and Anthony up to the table, and we're going to do a little switching around here. We have reserved lots of time. Part of the reason this is a 2-hour briefing is we wanted to leave plenty of time for your questions and answers. So we'll have about a half-an-hour reactor panel, and then we'll turn things over to you guys. So start thinking about what your questions are. Why don't you guys come over here? It's a little easier to see. Yeah, come over to this side. I'll take this one. These are, go take those two. So before I take a seat, just to really introduce the people that need no introduction here, but really two leaders in our state working diligently to try to improve the performance of the Medi-Cal program and improve access to care. Toby Douglas, the director of the Department of Healthcare Services. I'm sad to say that I'm not sure there are going to be many more briefings where it's an opportunity to introduce him as that. And Anthony Wright, the executive director of Health Access California. There's always, when we design these briefings, there's always a bit of hope and promise that the people that you really want to be on the reactor panel are actually available. And I'm really delighted that they're both were available and willing to participate today because of their leadership on this issue. So I'm going to take a seat. So let me just start with kind of the simple question, and I'll ask you first, Toby. What do you think are the key takeaways from this? Were there any surprises in these findings for you?
Thanks, Chris, and thanks to the authors for the great studies. Before I say, I do want to just first say, it is. I don't come to many of these briefings because of my schedule, but this one was extremely important because when I think of the Medi-Cal program, enrollment, and we focus so much on enrollment into the program, but really when it comes down to it, this is what's essential. It's access and actually making sure that our population is accessing services and getting the right outcomes. So in terms of the results and the takeaways, I'd first start with, I think what it shows is that Medi-Cal still has a lot of room for improvement, that there are clearly some findings that are showing we're moving in the right direction, but we have a lot of room for improvement in terms of ensuring access. And with the Medi-Cal program, we've gone through a tremendous transformation of moving populations into managed care. And what we've done creates the building blocks to really continue to push and move the access in the right direction. We have a managed care system now, upwards of 8 million Medi-Cal beneficiaries that are in managed care. When you look at the population of full scope, those that have access to primary and specialty care, they are pretty much all the populations now are in managed care. So now it's incumbent upon us to work with our plans on two areas. One is to make sure that they're engaging their members in ensuring that they understand. And a lot of this was around perceived and making sure that they understand what their usual source of care is and how to access that care, making sure our plans, and to the extent they're delegating down to provider groups, understand how to access and get the right access. The other is the responsibility of our plans as well as the state to make sure that there are the right networks, that managed care comes with a version more than, and we'll talk about Medicaid requirements, but our managed care comes with Knox-Keene protections and requirements in terms of primary care, specialty care, timely access, as well as the responsibilities of both our department as well as the Department of Managed Healthcare to make sure that our plans are ensuring the right networks, ensuring the access, and it's incumbent on us to make sure that's occurring on that level too. And then finally, it's incumbent upon us to be just like this, which I think is going to continue to push the envelope in terms of data transparency, is making sure that we're reporting out how our plans are doing, how they're performing, to push them to be accountable and push to make sure that ultimately our Medi-Cal beneficiaries are receiving the right access in the right setting.
Anthony, same question.
So again, my name is Anthony Wright. I'm the Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition, and I guess I would be remiss if I didn't just take this opportunity to publicly thank Toby for his years of service in a very challenging role, since I don't know if I'll have the opportunity to do so in the next couple of things. So I just wanted to say that I know that's shared by a number of my advocate colleagues as well. And with regard to these results, I mean, I think the findings seemed for us to refute two ends of the spectrum of the debate around Medi-Cal. It's not necessarily the viewpoint here in California, but let's remember that there is this wider political national context where the very value of Medicaid coverage in general is actually seriously questioned in the national political debate. That there is 24 states that have not even taken up the Medicaid expansion, and the talking points by political opponents of reform is that Medicaid coverage is not worth it. It's not it's not worth. It's no better than being uninsured. These are. This is what our discourse says, and I think it's important to sort of recognize that baseline, that's just utterly ridiculous, and that if you do any sort of survey of patients and indicate what their satisfactions are, what their access is, that yes, there are issues, and we'll get to those in a second, but you just recognize that it is just the people on Medi-Cal certainly believe that it's hugely valuable to them. They appreciate it, they benefit from it, etc. And and it's not just the political opponents of the ACA, however polarized that is, but sometimes in the debates, even here in California, you hear people saying Medi-Cal is nothing but a license to hunt for a hunting license, a license to hunt for a doctor, or that it's not some people in the more pitch the battles around Medi-Cal rates, etc. So we should acknowledge that the program is a valued program for the system in general and for the beneficiaries in specific. That being said, this does unveil with some rigor more than and confirms much of the anecdotes and stories that have come to our office, have come to many consumer advocates, have certainly come to you, of the real issues with regard to access, with regard to being able to get in to see whether a primary care doctor or a specialist to be able to to get at the care that one needs when one needs it. I was surprised about. I think I wasn't shocked by the differential between Medi-Cal and employer-based coverage. I think that's something that people understand. Although I think the disparity in some of those areas where it's twice as hard to get in to see certain types of to get certain types of treatment and care. That was a big gap. But I was really actually surprised by the difference between Medi-Cal and Medicaid in other states. I just got to say. I mean, in California, we tend not to want to compare ourselves to other states because we believe we're better than that. And frankly, we are. I mean, this is, when you think of what the other Medicaid states are, those are states, including those 24 other states that don't have enough have not put enough political value in Medicaid, that they're not even expanding the program. We may want to compare ourselves to the New Yorks or some of the New England states or Oregon and Washington, but I don't think we like to compare ourselves to the West and the South and some of the other states that have not invested in that. So for us to be lower than that is troublesome, I think, and so I think it reveals. So both stats do show like a real issue, that the uncomfortable fact that we are that this, if it's not, it's close to a two-tier healthcare system, which is what we're trying to move away from with the Affordable Care Act. And so we need to. This needs to be the top priority of the governor and the legislature moving forward.
Thank you both. So. We presented today the results of both consumer surveys and physician surveys, and I just want to ask you both about this approach and other approaches to measuring access to care. In some circles, consumer surveys in particular are sometimes maligned. And yet in California, I think we've invested a lot in the California Health Interview Survey and nationally in the National Health Interview Survey. We, the California Healthcare Foundation, certainly feel like they are really important contributors to the discussion and part of the data resources that we need to track and monitor a variety of issues. But I'd like to get your perspectives on this question about whether these types of surveys are useful, where you see them fitting in sort of the constellation of different ways we can measure access. Janet mentioned secret shopper as one approach. I mentioned that another study we're doing in collaboration with the department is this looking at avoidable hospitalization, so looking at administrative claims data. So there are a variety of methods, and I wondered if you could both sort of address how you see and the value you put in these kinds of consumer surveys, and then what else you think is needed. And I'll again start with Toby.
Okay. And I'll take it in a couple pieces. First, one thing I want to say, and it builds on what Anthony said about the comparison to other Medicaid states and some of the findings, which were, were surprising, but I would put it in the context. I know this was an extremely rigorous study, but I think there still is questions about how you compare Medi-Cal to other states, given, Medi-Cal, first of all, we have, 1 million restricted scope eligibles getting, emergency room services. How are you able to take those out? We have share of cost, where a large population of Medi-Cal can get share of cost, and how are they, how do you take into account the fact that they're not on Medi-Cal at certain times, as well as the retroactive coverage, and so the timing. So what I would say is the most important thing from my perspective is looking at it just in the lens of Medi-Cal. How are we improving, over time rather than compared to Medicaid or ESI, since the populations are so different? And again, acknowledging there was a lot of work done to try to normalize, but it's still very, we have a very big population, and we cover more than, as well as the sickest of the sick compared to other programs, both ESI as well as Medi-Cal. In terms of the question of whether these surveys are important, absolutely. There's no question that this is an important way to understand and proceed. We see access from multiple domains, from consumer surveys to then back to what I said about actually looking at encounter data. We're doing a lot of work on actual and continuing to improve encounter data. So we got to look at access from multiple dimensions, from beneficiary member access, as well as from what are we seeing in terms of actual utilization in the data itself that we're getting reported from plans and providers, to continuing to look at the overall provider networks. And so we look from all those different dimensions. Again, the same with providers going directly to them, but also going to plans and medical groups to understand their networks, and use all of it together to get a picture of whether we have sufficient access.
Okay. I think Toby's point with regard to the issue of what type of Medi-Cal is it, because Medi-Cal has for many years, including in the period of the study, been not one but maybe a series of programs and hundreds of aid codes, in fact. And so the question of how to distinguish it, and since we have really put our eggs in the managed care basket in terms of addressing this issue, that has been the sentiment that has been most recently stated by the governor in the Medi-Cal rate debate. Then I would be curious from the researchers to find out how much can we identify, was the population that we're identifying, which is not the age blind disabled, which is not the kids, but it really is the adults, how much of that was a managed care population versus some of the other populations that Toby indicated. Because again, I think if the stated answer to some of these access questions is improve managed care, we need to know if that's what we're measuring. To the broader issue of consumer surveys, it's not a surprising statement by a consumer group that consumer surveys are important. But I would say that they are useful, but not, but have their limits. And in particular, I want to recognize that the most, in any population, even a Medicaid population, which is in some ways poor and in some ways sicker, most people, only a percentage of any population is going to need major medical care in a given year. And so when you ask people their satisfaction, their ability to get into a doctor or whatever, that the vast majority of people will be happy to have a card in their pocket and that feeling of security. And so, we see these it's interesting, even on commercial insurance, you see these high rates of satisfaction with insurance for people who generally don't use it very much. It's only when you add, the more rigorous example is to go and zero in on the people who, because of their ailment, an MS patient, an AIDS patient, a cancer patient who has to have multiple interactions with the system, they're the ones who can tell you, what's going on. And so, frankly, even though some of these differences that were identified are not big, in my mind they're bigger than they appear, because I presume you're dealing with this in the smaller universe of the people who are actually using care on a regular basis, rather than the people who have to remember, oh yeah, the last time I was at the doctor's office, that was 8 months ago, which is a decent percentage of the population. So I want to recognize that. I think so I think they're very important, but they have, but it can't be the only thing. And certainly as advocates, we've been more focused less on the sort of research after the fact, although that's important to provide policymakers overview, but on the work of enforcement to when people have a problem, or even proactively, how do you prevent the problem to begin with? And so one of the things that we were very pleased, perhaps anticipating this result, is the work of the chair of the Senate Health Committee, Ed Hernandez, in authoring SB 964, which was signed into law by Governor Brown a couple weeks ago, that we were the sponsor of, to make sure that there are annual reviews of timely access, of network adequacy, of Medi-Cal managed care plans, and that provides sort of a proactive approach to addressing this very key issue. And in addition to the kind of regulatory work that the Department of Managed Health Care has done and needs to step up and do more of, which is the complaint-driven type approach, where and again, that has its own issues. Can people complain if there's not a place to complain to? This is an issue that we've complained about with the department. So those are so a complaint-based approach, sort of an overview, proactive review approach. I think those are some of the things that are important, as well as sort of how is the person's experience moving forward? And again, one of the reasons why we think the review is important, but also, and the marker of timely access to care is important, is that the timely access to, most people don't have a sense of, are there 2,000 or 3,000 doctors in their network? But what they do know is, I can't get in to see a doctor for 5, 6, 7 weeks, if that. And that's and so metrics that consumers can understand, as opposed to many of the things that are a little bit opaque for the average consumer.
Great. Let me ask, a few years ago, in partnership again with the Department of Healthcare Services, we conducted a survey of Medi-Cal enrollees. Let me just, if I might ask for a show of hands, those of you who joined that presentation a few years ago. Any few people? I highlight that for a couple of reasons. One is I think it does show how committed the department is to this issue. But second, because it addresses one of the issues that Toby raised, which is this differentiation between those who have partial scope access to emergency services only versus the full scope enrollees, which is really hard to do in these surveys. And we can ask Inez and Sharon to comment more about that when we get to the Q&A section with regard to these surveys. But I know in that case, we started with administrative data. So we started with who was actually enrolled in Medi-Cal, why were they enrolled in Medi-Cal, how long had they been enrolled in Medi-Cal, and then could differentiate findings there. So I would commend those who haven't seen that work to go to our website, CHCF.org. I think if you probably type in the search box enrollee survey, you can pick it up there. It is remarkably consistent with some of the findings here. So I think the issues that Toby raises are very important. And nonetheless, some of the differences do persist even when you're looking at full scope beneficiaries. The third reason I would commend you to that is a series of micro-documentary videos we did that accompanied the enrollee survey. We stay very data-driven. This is a very data-driven briefing, and it's important to be data-driven. Anthony mentioned so the anecdotes, the calls that they get, the calls that come into the Department of Healthcare Services. We featured micro-documentary videos, 3-4 minute videos of, I think it's 4 or 5, I think it's 4 enrollees. There's a video with Toby as well, and where they tell their story about their experience with the Medi-Cal program. And I think as both of them are describing to you, it's nuanced. It's not all good or all bad. Some of them are incredibly grateful for the access it provides to care, and yet still have problems. So it's really, and it does humanize this beyond the statistics. So if you haven't seen that, it's something I think we're really quite proud of at the California Healthcare Foundation. I think we need to do quite a bit more of. One of the strengths of this work was this controlling for differences in the populations, and notwithstanding the fact that we can't control for all the differences, I think this question about, well, how are Medi-Cal populations different from other Medicaid and other employer-sponsored insurance populations? And so we did, in a pretty rigorous way, try to control for as many of those differences as we can. The Equal Access Statute, the so-called Equal Access Statute under Medicaid, which really speaks to the issue of provider payments, but it doesn't differentiate between it doesn't say whether you should be comparing access in a simple way, just looking at the two populations, or you should be controlling for these differences. I'd like to get your perspective on that issue. As we think about what we expect out of the Medi-Cal program, which of these comparisons do you find to be most useful, or would you look at it in some different way? Is it the simple comparisons that's the standard we should be holding it to, or is it for people that are of similar background in terms of their health status, in terms of their socioeconomic status? That's kind of the apples to apples comparison we should be looking at. So let me start with Anthony, your perspective on that.
Well, I mean, I think, what should be the standard? The standard is that patients should get the care that they need when they need it, where they need it. I mean, that the idea, and it's not like there aren't these issues in the commercial world. It's not like there aren't these issues in covered California. You might have seen a couple of headlines this year on the term narrow networks. And this is this is a live issue in other contexts as well. I mean, we shouldn't put all of this at the door of Medi-Cal, but and so we need to resolve this issue broadly. And one of the reasons, and not to one of the reasons why SB 964 was important was that it was broad-based to all plans, commercial plans, including covered California plans, including Medi-Cal managed care plans, perhaps creating some apples-to-apples comparisons, standardizing the reporting by these different market plans, but also making sure that we look specifically at just the Anthem Blue Cross network for Medi-Cal. Is it different, or is the experience of access different than their covered California or commercial plans? And looking at that, so I think there is. So number one is it may be that we want to improve in all these areas, not just in Medi-Cal, to get to a standard on the private side that if the private side is inadequate to begin with. So that's in terms of improving. But in terms of for improving the rate, I think the key thing of the rates, or the provider rates, is that at the end of the day, we need to provide that level of care. And I'm not sure it's the experience of the consumer about if there's I'm not sure it's the person's experience as an individual. They want to know, can they get in to see the doctor? I'm not sure that matters. I think for the purposes of the rate negotiation, that's a question better left to Toby. But I think for that point of view, we need to just make sure that we're meeting these standards and then have the regulatory regime so that when we're contracting with a Medi-Cal managed care plan and the managed care plan is agreeing to a certain standard, that standard is being met. And if they can't do it if they come back and say they can't do it for the rates that are being provided, then we have the conversation that impacts the budget.
Mm-hmm. Toby.
Well, first of all, it's just this context. I mean, the Medicaid sufficiency standard, which we had to use. So going back to when we went through the provider payment reductions several years ago, that was the lens we had to look through in terms of ensuring whether we could achieve those reductions and ensure sufficient access. The world really changes when you have the context of managed care. This provision that we're talking about here only applies in a fee-for-service. So when we move into managed care, which then again most of our population on the medical, so dental aside, this is very important and continue something that we're going to need to look at going forward. But on the medical side, it's all these rules don't apply in the Medicaid side. What applies is the managed care rules, and for us, it's both the federal managed care rules around access and network adequacy, and then over which are more stringent in our case are our Knox-Keene requirements. So it really, this is where I'd agree with Anthony. I mean, it comes down to ensuring that we're complying our plans and are complying with those standards in terms of access to primary care, assigning primary care, the specialty access, timely access. That's what governs our program now and how we need to look at it. And then, did you want me to talk about rates, or that's the next question?
I didn't have a question about rates, but if you want to address them, you're.
Well, I was going to do it in the next question, so I can do. I mean,
Sure.
So I mean, it dovetails on this. Is when you have rates are clearly an important part of the equation. There's no question that what you pay providers is going to be part of the access equation, but it's not the only piece of it. There's so many other ways we have to look at access, and we'll talk about that. But more importantly is you can't look anymore at the rates that, we continue to say, oh, Medi-Cal is the lowest payer for certain services. We are definitely still very low, but it's not the fee-for-service rates that drive the decision-making of our plans. It's whether they have to comply with the Knox-Keene requirements, DMHC, and our requirements to make sure they have sufficient providers in the network. That means they're going to have to negotiate rates to ensure they meet with those providers. They're not setting it just on fee-for-services, setting on what it takes. So when you look at what our plans pay providers for primary, it's more than the Medi-Cal fee-for-service in pretty much all cases, and specialty in many cases up to Medicare or higher because they need to ensure access. So the system, what I'm saying is that when you have the protections of managed care, that's going to drive it coupled with what the rates are going to be, that those two are going to work together. And that's not to say that that there aren't policy needs to be at times to come in and infuse additional money in certain areas, and that will be part of the policy debate going forward. But we also have a structure within managed care and network requirements where that happens on the natural.
Great. So my final question before opening up to all of you, so I hope you have your questions ready, and maybe building on what you just said, Toby, and I'll start with you, is what do we do to improve access? So you've talked now a couple of times about the expansion of the managed care program as one key strategy of the department, and transitioning people to managed care where they were in fee-for-service, and then certainly the expansion population is all primarily in managed care. What else? What other actions is the department taking? What additional actions are needed? I mean, you can, and if you want, you can expand upon the role that the health plans play. But I'm aware that you're doing a lot more beyond the managed care piece of this. So, how do you think about that in terms of the work that you have underway and the work ahead?
Yeah. And so I start again with that point is that we're not going to solve access by and you said it earlier, so just building on what you said as well, which is, we can't, we're not going to solve provider access by just rates alone. That's not the solution, and we're not going to solve it with physicians. We don't have enough. It's got to be looking differently at how we actually provide access. And so that's what we're trying to do as a department. And I think one of the key areas is, and the survey showed this, one of our biggest providers and one of the reasons why we've had sufficient access in many areas is because of our federally qualified health centers. We have a very, very wide and growing network of federally qualified health centers that serve as an important provider of primary care within the Medi-Cal program throughout the state. And yet they are constrained based on providing care on a visit-based, volume-based system. And what we're trying to do is work with them on providing care differently, looking at, as Chris laid out earlier, group-based care. We want to look at ways that they can be rewarded and incented for providing group-based care, for providing telehealth, for providing email visits, for looking at specialty consults where they can be rewarded again for doing that, whether it's e-consult, phone calls, consult, looking at home-based visits. There's multiple ways that for our population care and access could be expanded beyond the scope of just additional physician visits. But we need to tailor the payment to, what the managed care is just a starting point. And then we got to work on payment and delivery changes. And so how do we pay differently for our federally qualified health centers? And then how does that allow them facilitate delivering care differently? That goes to other areas, and that goes to our 1115 waiver beyond just federally qualified health centers, of trying to incent medical groups and our plans to be able to delegate bundle payments down to groups to do similar approaches across, whether it's inpatient, outpatient setting, so that they can use their dollars in a way that facilitates access in different ways, and then they get rewarded for that. So on us, it's going to mean we have to think through also how do we pay, the plans, part of the way we set our rates is based on their experience, and that's based on visits. But then we have to evolve as a state then to be able to delineate these other types of alternative touches, is what we would call them. They're not your typical physician visits, but other touches, whether it's email or other, and how do we account for those as we then look at the experience-based rates over time, so it isn't a race to the bottom, that they're providing different types of access, but the rates aren't accounting for that over time for the plans to then incent providers. So there's multiple, and then the final, I think, is around, and this is, the exciting part is looking across behavioral and physical health. How do we use the two together to expand access? Not again, are there ways that those two can work together, not to necessarily increase, again, physician visits, but using those systems as the touches that might go on one side or the other to work together on expanding the right access.
Anthony?
So I think, first of all, I think that better data is always, this is helpful to move us along, and better data is always welcome. I think that we could probably do well to get better data, for example, on the regional work. The researchers mentioned that the regions that were too broad to sort of really dive in, because I suspect that, I think many of us suspect that, whether it's an inner city community or a rural community, and the regions just, regions had too much of a mix of urban and rural areas to be able to identify some of the particular areas. For example, in rural California, I think, they also mentioned by specialty that there's wide variations between different types of specialties. And so again, something that looks closer at some of these issues can really identify the problems that's going forward. And I think that just bespeaks the necessary that as we've transitioned to a world of Medi-Cal managed care as our primary vehicle, that then we need an appropriate regime of accountability for looking at this and being able to identify it, and making sure that some of these problems aren't masked over because of some of the more global numbers. I would be remiss to say that I know that there is focusing on managed care is important, but I would also not want to ignore the population that is served by limited scope Medi-Cal, and fundamentally getting them the primary and preventative and other access to care that they need, as, for example, Senator Lara envisioned with his Health for All proposal this past year. That is a policy choice and investment that we can make to improve the healthcare system in general. But again, back to this point of, yes, maybe you can call it carrot and stick, oversight and accountability as well as resources and rates, that this is, it can't be one or the other. This is not going to be solved purely by spending, but it's hard to imagine solving this issue entirely without any investment And I know that there's the opportunity in the waiver to try to get federal contribution for that, but it also does take and probably will take some investment on part of the state of California, and for there to be the political will to really deal with this. And so again, it has to be with the accountability. 964 is a beginning platform for that, but we think that there's more that we can do, and that especially not only the partnership with DHCS, but with the Department of Managed Healthcare that was highlighted to really make sure of that. But we need the political will to make this one of the top things we do. California's made so much strides with regard to the Affordable Care Act, with regard to reducing the number of uninsured in half, with regard to the work that continues to do on enrollment. But we need to make sure people get the care. And my last point is simply that part of that political will, I think, will come from people in this room, but I think it will come from the transition of the Medi-Cal program itself. It's been said before that this is not your mother's or your grandmother's Medi-Cal anymore. And I think that's true, not just because of the managed care transition. It's not just because of the ACA expansion per se, but with the elimination of the asset test, with the other broader frameworks of the ACA, this is now the safety net for all of us. If we're between jobs and we don't have an income by ourselves or a spouse, we're on Medi-Cal. We're on Medi-Cal. For a college student, we're on Medi-Cal. And so it will be interesting for the researchers to figure out, how does these numbers change when people with middle-class expectations start joining it, rather than people who have learned to live with low-income expectations of what services are provided to them. I think that will be a really interesting dynamic that goes forward. And again, as that population changes, that's 11 million Californians, but also a much more wider group of the potential Medi-Cal enrollees who might be in or out of the program over the course of several years. I think that will change the political dynamics, hopefully, to really address this issue, and hopefully we can get ahead of that rather than just wait for the reaction to that. I think that's the challenge for us. Just to give you an example of this, a colleague of mine was talking to a freelance writer writing for a noted national newspaper, a reporter for a headline newspaper, and the reporter was on Medi-Cal. And so I think that's going to change this dynamic as well. And so I hope it does.
Well, great discussion. Thank you both. I apologize to those of you in this room that we ran a little bit long with this, but we do have 20 minutes for Q&A.
Bill Lewis with Assembly Republican Caucus had a question for Janet Kaufman, actually, related to the the survey questions on physicians accepting new patients. I was wondering the extent to which you were able to dig deeper in that question into capacity, kind of getting to what was just talked about. It's one thing to say you're accepting new Medi-Cal patients as a provider, but if you can only take a half dozen and then you're tapped out, how much has really been accomplished on access?
So I think that's a great question. It points to one of the limitations of our survey. We try to keep our survey fairly short, and so for this round, we really only asked a yes/no question about accepting Medi-Cal patients. But your point is well taken, that there's a big difference between, we can maybe take 5 more patients, or we could take 50 more patients.
I think Anthony made an important distinction a number of times, that when you're looking at people who have full scope or partial benefits, people who use a lot of health care or not a lot of health care, I kind of went back to the differences between the two surveys and the gaps in potential access to care versus realized access. And I noticed the difference in the phrasing of the questions. So did you get a doctor visit or a specialty visit in that year versus did you delay needed medical care or not fill a prescription? If I might get scolded here, but if I haven't been to see my doctor in 5 years because I haven't been sick, or I go to an OB but I don't go to a PCP or a specialist, that maybe that is, if we're using this data to reflect the performance of the program, that might be something, and maybe you can speak to that, how the questions are phrased in the different surveys.
Before they respond, I'm sorry, did you introduce yourself?
I'm sorry, I'm Sunshine Moore from California Association of Health Plans.
I think that's always a challenge with survey data, that the questions are worded differently, and so it can be difficult to compare across surveys. And I think part of the reason we have multiple measures is to try to get a different concept. So some are levels of use. Did you have a doctor visit? And then some are unmet need. So do you perceive yourself as not having care that you need? And I think they both are useful for providing a perspective. But I think in terms of one of the issues raised earlier about the different kinds of Medi-Cal enrollees, I mean, one thing we've done in the analysis is we limit the study to full year Medi-Cal enrollees. So part of that is because a lot of the measures are looking at access over the past year, but it also takes out some of the spend down, you're on a month, you're off a month, you're on a month issue. But it is an issue in surveys that there's a lot of error in reporting of coverage type, and I think that's going to become more complicated as the ACA rolls out as to what people call things going forward.
We can also, I think moving forward, we can get at the managed care part. So we can do that in the next analysis where we can, well, CHIS does get at managed care. And as Sharon said, we did restrict to full year, but our comparison group was also full year ESI. So it's also another, it was to try to get a more standardized in terms of coverage, but then that might be also a higher standard to compare to. And then as Sharon said, it's, getting the exact phrasing of questions is a challenge, but I think we chose indicators that try to get at need, so it wasn't elective, but so we tried to get at, did you, you weren't able to get a doctor's appointment within 2 days that you needed, for example. So we did try to get that at that.
Question in the back.
Thank you. Hi, I'm Abby Corsall with the National Health Law Program, and it was really great to hear all the presentations and the responses. Thank you all so much. I just wanted to ask a couple questions to the researchers, or raise a couple points sort of related actually to what Ninez was just saying and to what we heard a lot from Toby and Anthony on. It's, now that we have moved to a much more managed care focused model, I'm wondering whether future versions of these studies and surveys can account for that a little bit more. So for example, with the provider survey, I do think it's really interesting and helpful to have an overall picture of how many providers are accepting Medi-Cal, but for an individual consumer who's enrolled in a Medi-Cal managed care plan, that doesn't really give the full picture because not all of those providers are necessarily networked with that particular plan, and so the plan structure itself can impose additional limitations on people's access. And I think as Toby and Anthony both recognized, because of the managed care structure we have now and the protections we have in law through the Knox-Keene Act and the role of the Department of Managed Health Care, much more of responsibility for ensuring access falls on the plans rather than the state. So I also do think it would be helpful, as Ninez just described, to get a little bit more granular and look at how these data are breaking down at the plan level, so we can really get a picture of whether the different structures and the way the plans are meeting their responsibilities is impeding access. And then just one last point that no one has really touched on yet is I was really fascinated by Ninez and her team's findings about cost serving as a barrier, and I just want to raise the idea that maybe it's time to look at copays in Medi-Cal again. We don't have a lot of them, but I think we have a lot of research over many years that shows that even very nominal copays serve as real barriers to access, and this study obviously bears that out. And I think, now that we are in slightly better economic times, maybe it is time to look at that again. Thank you.
I would also just a couple things that raises for me, and then do you want to go?
No, you go first.
So one is just on the cost issue. When we looked at the transition of seniors and people with disabilities from fee-for-service to managed care, one of the responses back, or this set of many people, raised this issue of their costs had actually gone up, and we thought, how could that be the case? the copays aren't any greater, and sometimes they're eliminated. So why are people paying? If anything, they should be paying less, not more. And it was interesting. I mean, part of it was people wanted what they had been getting, and they were willing to scrape up the money to pay for it themselves, whether it was the name brand drug or whether it was the durable medical equipment. So I mentioned that by way of the cost issue, and affordability is not just copays, but it's other forms of expenditures. And then I would also, just in that context of comparing managed care plans, would really repeat myself. Something I haven't said today, though, is commend the department for its dashboard on the performance of the Medi-Cal managed care plans, because that does really, for the first time, I think, try to synthesize a lot of information about how plans compare in terms of an array of consumer experience measures and healthcare quality measures. And you can see, I mean, what's interesting, we talked about in the discussion about what the department is doing, what more can be done. You really can see that there are some plans that do quite a bit better than other health plans. Some of that potentially is just they're better at reporting data and capturing data, but that's undoubtedly that's not all of it. And so I think there are some mining those examples and better understanding what some of those plans are doing is something that I think we can do more of.
Thanks, Chris, on the dashboard, which big kudos to Chris and CHCF, because we wouldn't have been able to do it without their funding and their support from the get-go on it. So always a great partnership. On the secret shopper, I did want to say one big issue that we have to think about too is a secret shopper is very difficult in the context of managed care, where providers don't necessarily think anymore of Medi-Cal, but rather they're contracting with LA Care or Blue Cross or HealthNet, or in LA cases, they're, healthcare partners, or, down to different areas. And so you don't necessarily have a secret shopper. You go through, a member services or provider relations approach to getting assigned. And so how does a random call to a provider really, tell the story of whether there is there's an available slot, or if they even understand if they're taking Medi-Cal or not, because they might not even be structured in that way. So we have to think that through too as we go forward.
Well, I think it's, let me say a few things. It's unfortunate we didn't have more time to talk about the specifics of the secret shopper, because I think Toby's point that secret shopper doesn't tell the whole story is true, but we did do some things in this particular secret shopper to try to make it as realistic as possible. So I would say, and we framed our findings as folks looking for new patient appointments, and we county by county in the script that the callers had, we knew whether it was, we knew what the managed care plans were in that county, and the caller used the name of the plan in that county that had the highest number of enrollees, and where we could find a reliable provider directory. We tried to use the name of a plan that appeared that physician was indeed a part of. So really, fair points, Toby, but we thought about those and we tried to do what we could.
So steps you can take, and this was a secret shopper on primary care access. Correct. Probably greater hurdles when you're talking about specialty care access.
Yeah, we were really looking only at non-elderly adults in primary care. So I think you're right, Chris. Definitely when you get into specialty, doing a good secret shopper, it can be done, but it is an additional level of complexity.
Anthony, you wanted to comment, and we'll go back
just
up.
Number one is I would recommend, it's something that we've occasionally done as a consumer group, but we think that it's within the realm of departments, whether Department of Managed Healthcare or Department of Healthcare Services, to actually conduct secret shopper type surveys. Mm-hmm. And because you guys do know, what is some of the intricacies that to be able to test it. And again, I think it would be an appropriate thing for you or your successor to take a look at as a way of proactive monitoring of these types of issues. The one other just point I wanted to make of Abby is on the affordability. I thought that it was just weird that that Medi-Cal had worse affordability ratings than employer-based coverage. That was strange, and I would I hope that the researchers delve into that a little bit, because that's a policy. I mean, that's the one thing that Medi-Cal should all these other issues we understand we have to address, but that's the thing that we should be able to directly address and resolve as a policy question. And if we can identify that, if it's because if they can't get authorization for certain drugs, so they have to go off of coverage to buy it, or whatever the issue is. If it's more of an access issue that's masquerading as an affordability issue, but that should not be happening.
I think just one point on that it's important to remember that it's the respondent's definition of affordability, and it can be much less cost for a Medi-Cal person than it is for an ESI person, but they perceive it as a much bigger burden.
I mean, and I would take it. I mean, remember, copays are voluntary, so it could be everything from there needs to be more, again, back to education enforcement. Our providers making sure it's voluntary, to are we appropriately informing beneficiaries about what's required. So it's also that perception, what's true. But at some level it needs to be dealt with.
Hi, sorry, I'm Micah Weinberg with the Bay Area Council. I wanted to ask the researchers, so there's managed care, but there's a lot that is underneath managed care, which is to say specifically delivery systems. There's some delivery systems that rely more on, because of geography, solo practices, some where there are more FQHCs and so on and so forth. So if there's the statistical power, I would love to see broken out by county, or maybe in some case multi-county regions, how access is affected by the delivery system. Just looking at one of your slides, if only 40% of solo practices are accepting new patients, but 80% or more of FQHCs are, it seems like there's likely a finding about what kind of a delivery system in a county has a bigger impact on access. And I'd love any comments you have on whether that's possible or might be good.
Yes, it is possible. Thanks for the question. When looking at Janet's slides, I was thinking we should merge some of our findings with her findings. And we can get power. I presented 1 year of CHIS data, CHIS 2012. We can certainly do 12, 13 together to get at the county level. And it could be linked because we geocode CHIS for over 85%. Then we can actually link them to the county, and also even get more granular and get more at the city. And so there are definitely ways where we can link the consumer surveys. We didn't get a chance to defend the consumer surveys to the supply side, to the provider side.
And let me say, I think that's wonderful, and we should talk. I think on our provider surveys, we've been limited by the sample size, and we should certainly increase that. Probably the easiest way to increase sample size on the provider side is if these questions about participation in Medi-Cal and other insurance were to become part of the mandatory survey that the board sends out to everybody. That mandatory survey gets a 90+% response rate, and from there we would have the ability to drill down to a much finer level than we can do with any sample survey. So if anybody from the legislature is listening and looking for ideas, that's a piece of legislation that would actually, I think, help us a lot, at least on the ability to use the provider data to say even more about access.
Great. Well, just in closing, I want to thank our speakers who presented the information, who worked very hard to get things ready in time for today, to our reactor panel as well. I want to thank you for your participation. For those of you here in person, for those of you who are participating by webcast on the phone, you both have the opportunity to complete an evaluation. Please do. We're testing something out for the first time for those participating on webcast, which is where we get a lot of participation. So please take a few minutes to complete your survey. I'm not going to try to summarize the conversations too much. I'll just quickly say next steps here in terms of some of this work. I mentioned already that the work that Janet presented is already published on our website. And I don't remember, I think it was Sharon mentioned that the work that she and Inez are doing, we're aiming to have that published in the spring. And we will include both results for children and for adults with that information. I think if we don't have already, we will have posted on our website along with this briefing the data tables that accompany the slides that you saw today. I want to thank you for your terrific questions to really spark the conversation. And again, thank our presenters. With that, we're adjourned.
Thank you.